Well, when you think about legislation, you have to think about it from two perspectives. One perspective is we want to move legislation forward. We want to get good legislation passed. Another perspective is we want to block bad legislation. We want to make sure bad legislation doesn't move forward. So what we often do is we will find sponsors for good legislation, bills we want to move forward. And that's a very strategic position. You can always find any legislator who might be willing to sponsor your piece of legislation. But if they're not in the right party, and if they don't serve on a key committee, or if they don't have key influence, then the bill might not move forward.
So today I'm joined by nurse practitioner Dr. Ed Briggs. So you have your doctorate, DNP.
Doctor of Nursing Practice, right?
Okay. And you're quite, I know you, like we were talking before, you don't like to talk about it, but you are quite accomplished. I would say you're an expert in the subject matter of advocacy and, doing things within the Florida Nurses Association, American Nurses Association to advocate for nurses and to try to get legislation done to help.
Yeah. So I'll share how I got into that. So when we first moved to Florida, I went back to get my master's degree. And one of the faculty members there basically asked me, if I'd be interested in being involved with the Florida Nurses Association. I said, sure. And I kind of left it at that. And 2 weeks later, she came back and she said, congratulations. And I said, why? And she said, you're on the board of FNA now. So
what experience, maybe talk about what experience did you have prior to getting on the FNA? What were you doing before that?
I was very much involved in coordinating and being involved in local legislative efforts, meeting with legislators, talking about issues important to nursing, things like safe staffing, safe workplace environment. And this is 20 years ago. I mean, we're still fighting those fights today. We were regularly meeting with legislators, trying to convince them to move legislation forward that benefited both nursing and our patients. And so I've been fighting that fight for more than 20 years. But that's how I got involved. I recognized that we needed to do something about it, and that the only way to really do it is by engaging legislators. And we've seen some incremental changes here in Florida and some incremental changes nationally. So the job's not done. We've moved the needle a little, but not as much as I think we should.
So the main, maybe you can summarize, what is the mission of the FNA, the mission of the ANA is advocating for the profession of nursing,
right?
Would you say?
Well, it's twofold. It's advocating for the profession of nursing, making sure that everyone's able to practice to the full extent of their education and training, both advanced practice nurses and registered nurses, making sure that where we practice is a safe environment, but also advocating for our patients, making sure that we're providing evidence-based care to the highest degree that we possibly can. So both organizations advocate for quality care and trying to make sure that we're following best practices to provide that care and meet the needs of our communities.
What's the biggest issue that you have to, fight for or fight over? Is it, I would imagine, like staffing? Because that, when you think about advocating for nurses, they can take care of their patients better, which ultimately it's better patient care if you have better staffing. So is that one of the biggest issues that you advocate for, is staffing?
Well, I think that's one of the key issues. I mean, we all recognize that safe staffing is a necessity. The problem is, as a profession, we haven't decided on a unified approach. So we're still having the fight of fixed ratios versus acuity-based staffing. And so one of the barriers we have to actually moving legislation forward is that we don't have a unified position. So many organizations advocate for fixed ratio staffing. Other organizations will advocate for acuity-based staffing. And so when those organizations go in and talk to legislators are getting two entirely different messages, and they don't know which one to follow. So we very much advocate for safe staffing, both at the Florida Nurses Association and at the American Nurses Association. And we recognize that we want a combination. We want staffing ratios that are based on acuity. We recognize that 5-to-1, 4-to-1 may sound great, But if you've got 4 acute patients, then it may need to be 2-to-1 or 3-to-1. So we need a mixed ratio. We need a ratio of delivery of patient care based on not only the ratio of nurses to patients, but also considering the acuity. And so that's one of the big issues we're fighting for.
So who would make that? Would that be like a law that is passed in Florida or passed in Washington to affect everyone nationwide? Like if you, has there been a proposal that's like, if you work on a med surg floor, you should be capped at 5 patients or an acuity, whatever that may be? Or is that a Florida law, nationwide law? How does
it would be state by state. Basically, the laws governing how hospitals operate are governed at the state level. And so we would have to pass legislation in each state. So for example, California has a fixed ratio bill. I believe Washington State also has a fixed ratio bill. So they've got legislation that basically mandates nursing staffing. There are some states that have developed acuity-based staffing. So it has to be done at the state-by-state level. Here in Florida, we've tried to move bills forward. We've not been successful to date. We haven't given up. We still are working on that. One of the things we can do at the national level is the JCAHO guidelines and the OSHA guidelines both state that hospitals have to have safe staffing, but they don't define what safe staffing is. So that's one of the challenges we have. If we're not going to define what safe staffing is, how do we determine that a hospital is providing safe staffing? So one of the issues that the lobbyists for ANA are working on is working with those organizations to develop regulations at the federal level that would define what safe staffing means. And this way, we may not be able to pass a national law, but at least we have a clear definition of what's required for safe staffing for hospitals that participate in Medicare and Medicaid, which is every hospital in the country.
So you mentioned California and Washington. We were talking earlier about where I had worked and stuff. I actually did move to Washington State for 1 year, and I worked out there in a hospital. And they had a union out there, which maybe you know more about unions than I probably do. But when I was out there, they had a nursing union, and they probably had those safe staffing caps, or what you referred to. The only thing that I saw from the union was like they would never even they wouldn't even think about asking you to take an extra patient. Like I was never asked,
right?
Can you take this patient for even 30 minutes? Like you have a discharge coming up, they're going to be out the door. Can you just take this next patient? Your patient's going to they wouldn't even ask that question. And it seems like that's very common here in Florida,
Right.
which is where I've done most of my nursing career. But it's interesting that you mentioned that. So how do unions come into play with all this?
Well,
How do they?
The phenomenon in California isn't based on the union, that's based on the legislation. There's actually very precise California legislation that restricts what can be required of nursing. That includes mandatory overtime. They've eliminated it. They can't require nurses to have mandatory overtime, where in certain states it is allowed. So you can be required to stay overtime if somebody's a no-show. So it's legislative. Unions act as a voice for the nurse. They act as a voice in the negotiations of contracts and benefits. And so in some positions that could be very powerful and influential. Unfortunately, we have right to work states. And so here, Florida is one of those right to work states. So we have unions here in Florida that negotiate contracts, that negotiate staffing ratios, but you serve at the will of the facility. So the ability of the union in a right to work state to have such restrictive provisions on staffing, they really can't do it because they have very limited influence in a right to work state.
So it's not like a union in New York or California or Washington.
No, it's completely
different set of rules.
Right.
Yeah.
Because
I always wondered why. I've heard the right to work state thing, but then I'm like, well, why are there even unions here then? I don't understand that. Why? What are the unions doing if it's a right to work state? They do help the nurses in some way?
And they very much negotiate benefits. They negotiate salaries. They can negotiate work environment to a certain level, but they're also negotiating from not as strong a position as other states. So other states where you've got more bargaining power on the union's part, they can talk about no mandatory overtime. They can talk about other provisions where in a right to work state, having those negotiations are not as effective because they don't have a best position for bargaining.
Mm-hmm. Not as much leverage.
Right. They don't have as much
Yeah.
leverage. And so that's one of the restrictions unions have in a right to work state. And I believe 24, 25 states are right to work states.
So what is the process like with the FNA? Maybe they're similar or different in some ways. With the FNA and the ANA, how do you actually get to the point of going to get something legislated where you're talking to representatives in government to actually try to make a change? What's that process like?
Well, when you think about legislation, you have to think about it from two perspectives. One perspective is we want to move legislation forward. We want to get good legislation passed. Another perspective is we want to block bad legislation. We want to make sure bad legislation doesn't move forward. So what we often do is we will find sponsors for good legislation, bills we want to move forward. And that's a very strategic position. You can always find any legislator who might be willing to sponsor your piece of legislation. But if they're not in the right party, and if they don't serve on a key committee, or if they don't have key influence, then the bill might not move forward.
Thank you for joining me on the podcast. Don't forget to subscribe and let me know in the comments who you'd like to see me have on the show next.
And so you need to find a legislator who is serving on a committee or who is in a leadership position or who has influence, and you want to get them to sponsor your bill. So safe staffing bills or safe workplace conditions, such as surgical smoke. You need to find a key legislator to sponsor those bills. And so the organization, whether it's FNA or ANA, we have to have a really strong relationship with those legislators and convince them of the value for their constituents relating to that piece of legislation, that the legislation is going to benefit the people that they serve. Okay? Once you do that, once you've got someone sponsoring a bill, then you have to get that bill through committee. And so here in Florida, one of the challenges is you've got a very limited time period to do that. We have an 8-week legislative session. So any piece of legislation has to be done in 8 weeks or it dies.
Till when?
That's it. You got 8 weeks to get everything done.
Whatever you're proposing
Right.
has 8 weeks, and then you're starting over again.
And you're starting all over again. And so here in Florida, because we have such a restricted cycle, you've got 8 weeks. We get a legislator to sponsor a bill. Then the leadership gets to decide how many committees have to hear that bill. And so those bills have to be scheduled in different committees. And then they've got to make it through those committees. And then they have to pass the committees before they can go to the floor of the House and the Senate where they pass or fail. And so one of the challenges you have is not only do you have to have a sponsor who has influence to move that legislation forward, but you also have to have committees that are willing to schedule that bill, hear the bill, and then pass it.
And they have to, I'm assuming they have to read it and
Yep.
understand it. And how big are these bills?
Sometimes they could be 10, 15, 20 pages. Sometimes it could be 1 page. So it really depends on the issue that we are working on. So, for example, the surgical smoke bill, which Florida Nurses Association has filed repeatedly for many years. This would basically require smoke eaters, devices that suck up surgical smoke. We know that surgical smoke is harmful to the nurses, to the OR techs, to the surgeons.
And they're just wearing masks.
They're just wearing masks, but they're still inhaling it.
Yeah.
There's a lot of literature that shows that surgical smoke increases cancer rates and also allows for the transmission of HPV and other viral particles. And so if you happen to inhale some HPV during the procedure, you can develop oral or esophageal cancer from that HPV. So in states where surgical smoke evacuators are required, we've seen much fewer rates of those kind of complications in nurses, surgeons. And so the Florida Nurses Association has filed this bill repeatedly over and over and over again. It's got lots of evidence supporting it. We find good sponsors. And the bill is only a few pages long. It basically just states that every OR has to have evacuators to suck up the surgical smoke when we use a cautery. Simple bill.
It makes sense so far.
It makes perfect
It
sense.
makes sense. Yeah.
One of the problems is it's typically scheduled for 3 committees in Florida. So you've got to get it through 3 committees. And then you have to have the chairs of those committees willing to place that bill on the agenda and be heard. So we've not been able to pass that bill yet simply because of that barrier. We just can't get it tabled. And because there are very powerful entities such as the Florida Hospital Association, which opposes the mandate for surgical smoke evacuators
Because it costs money.
because it costs money.
Okay. What is that? Like, how much money are we talking? Is this something that has to be, is this like a machine that sits on the ground, or is this like has to go into the air system?
It's basically a small vacuum with a small device that you attach to the cautery.
Oh,
Now,
like handheld.
Yeah, it is. It is not. It's an additional expense, but it's not a huge expense.
Yeah.
But we can't get that bill passed. Many other states have passed it. Again, this goes back to regulation. So as of right now, OSHA, the Occupational and Safety Health Administration, the federal body that governs safe workplace practices, does not require surgical smoke evacuators in the OR. That's one of the things ANA is working on, modifying the OSHA regulations to require it.
And so if the ANA got that done with OSHA, it would, the Florida nurses, they wouldn't have to, it would be nationwide.
It would be nationwide.
Okay.
It would be an OSHA requirement for any hospital that participates in Medicare and Medicaid.
Mm-hmm.
So that's the process. You get a bill, makes perfectly good sense. We find the sponsors, gets tabled to the committees, and then hopefully it passes, but often it doesn't. And so one of the things that the Florida Nurses Association does is we have an annual advocacy day. That's where we go up to Tallahassee, where we lobby legislators on key pieces of legislation, where we talk to our legislators, we educate them about these bills, and we try to move these bills forward. One of the challenges is there are close to 200,000 registered nurses in the state of Florida. Okay? Lots of registered nurses. If we have 200 nurses showing up at advocacy days, that's a good number. We have less than 1% of nurses showing up to advocate for our profession on those days. And the legislators recognize that. They know how many registered nurses there are in the state of Florida. And if we've only got 100, 200 showing up, they recognize that. They recognize that this is not a constituency that's vocal, so they don't have to worry about it because we're not up there lobbying. Where the physicians groups, you will have much larger presence. Other organizations will have much larger presence up in Tallahassee. So one of the things that we need to do as a profession, we need to be there. We need to go up to Tallahassee. We need to talk to our legislators. If we can't get up to Tallahassee, we need to do it in our home districts. We need to find out who our legislators are. We need to find out what bills are being considered. We need to meet those legislators face to face and educate them about the bills and gain their support for this legislation.
So this flows down all the way to each individual nurse,
every
everywhere
nurse.
They're working.
That's it.
Yeah.
It's great to say, hey, ANA should do something or FNA should do something, but we need to, as a profession, come together and work to advocate. We need to know who our legislators are. We need to be in their face, not confrontational, but make sure they know who we are, make sure they know that we're nurses, and make sure they know the importance of these pieces of legislation.
Has there ever been a nurse or physician or anyone from healthcare in a government position in Florida?
Oh, yeah.
Yeah.
We've got several doctors right now who are legislators up in Tallahassee. We have, I believe, one registered nurse who is a legislator in Tallahassee. Up in the U.S. Congress, there are, I believe, 13 or 14 physicians who are congressmen or senators, and there is one nurse. And so we are not, because remember, there are 5 times as many nurses as there are physicians. So why don't we have 5 times as many legislators who are nurses than physicians? Because nurses, for some reason, we've gained this perspective that we shouldn't be involved in politics. Somehow it's kind of dirty. But we need to recognize that unless we are sitting at the table, unless we are heard, then we are probably on the menu. They're not really going to be looking at our best interest. They're going to be looking at the best interest of the folks at the table.
And politics is so complicated too. Like you talked about how a lot of it has to do with money, like where, sometimes you have to follow the money, like who's giving the donations, which is sad to think about, but
Yeah.
that's another topic. But yeah, a lot of it has to do with where are they getting their money from, where are they, who's influencing them. So,
but I'm very much a believer in the power of numbers. And, if we had 10% of registered nurses, 2,000 nurses showing up to Tallahassee for advocacy days, we could probably get any bill we want passed. We would stop the city of Tallahassee for advocacy days.
They just have to see that there's enough people that are actually going to do something, concerned about it.
That are concerned about it, and talking and educating them, making it very clear, this is an issue that's important to us. This is the way we want you to vote. But if they're not hearing from us, if they're not seeing that we are unified, then they don't care. I take that back. Not that they don't care, but they don't see it as being a priority issue.
It's not at the top of the list.
It's not the top of the list.
Yeah.
And so you've got 300, 400 physicians showing up, telling them about how bad nurse practitioners are, and you've only got 50 nurse practitioners showing up to lobby. And again, that's just a generalization. But they're seeing a lot more physicians than they're seeing advanced practice nurses. So who are they going to listen to?
Now, does this process work the same for the ANA?
Yeah.
Too? It's just being done in Washington.
Just being done in Washington.
It has to go through all the committees.
It has to go through all the committees.
Yeah.
So any bill that's filed has to be approved by the Senate President and the Speaker of the House. Once it's approved by them, they can assign it to as many committees as they want. Once that's done, it's up to the committee chair to decide whether that bill is heard. So you're kind of seeing that there are a lot of things that are stacked up against us. If the Senate President or the Speaker of the House doesn't like the bill, it's dead. If the committee chairs don't like the bill, it's dead. So we really need to have a lot of contacts and a strong relationship with those individuals. And one of the problems we have is we have allowed, as a profession, to move partisan politics into our advocacy. There are folks that are on the right who don't like us at, working with Democratic legislators. There are folks on the left who don't like us working with Republican legislators. And when we do that, when we fall into that partisan divide, we don't move our legislation forward. We need to understand that we're not advocating for a party. We're advocating for the issues that are important to us. And that means we have to work with the legislators that are in power and convince them of the value of the legislation we're trying to move forward. So, for example, there is bizarre, archaic rules relating to advanced practice nurses. We can be independent practitioners. We can have our own practice. We don't need to be supervised by physicians in many states, including in Florida. But under the regulations for Medicare and Medicaid, we can't prescribe diabetic shoes. We can send a patient to cardiac rehab or to pulmonary rehab. That requires a physician. Makes no sense.
But what's the real reason for that?
Well, it goes back when these regulations were written, the standard was advanced practice nurses worked under a physician. So it wasn't an issue. You could just go to the physician and have them order it. That doesn't exist anymore. So these regulations are outdated. So there is a bill, the ICANN Act, which would remove those antiquated rules and allow advanced practice nurses to practice to the full extent of their authority and their knowledge and their training. The challenge is, right now, Washington, D.C. is so partisan. And so as we approach legislators on the right, nurses are on the left are upset. If we approach legislators on the left, the nurses on the right are upset. And so we're working against our own best interests. We need to understand that we need to get away from partisan politics. We need to advocate for what's best for our patients and for our profession. And that means sometimes we need to find legislators who we may not agree with on all issues. But if they agree with us on certain key issues, then we need to work with them to move those legislation forward to benefit our patients and our profession.
What are nurse practitioners not doing now that you would want them to be able to do? Is there a couple things that just make sense that they should be able to do?
Well, I think here in Florida, we do have full practice authority for advanced practice nurses who are in primary care. So they're allowed to practice to the full extent of their education and training. They could do what they've been trained to do. They could provide care to patients based on what they have been trained to do. So we're able to provide services to communities in need, as well as, a broad spectrum of the population. The problem is how do you define primary care? And so here in Florida, we don't consider psychiatric mental health as primary care. So if you are a psychiatric mental health nurse, you have to work under the supervision of a physician.
So you can't have your own
No.
psych practice?
No.
Or
You have to work under the physician. If you are a women's health provider, you can't be an independent provider because they don't consider that primary care. So you have to work under a physician. So yes, having full practice authority here in Florida for primary care is great, but we need to extend that. We need to make sure that psych mental health advanced practice nurses, women's health providers, OBGYN, all advanced practice nurses are able to practice to the full extent of their education and training to better meet the needs of their community. The other thing is, and this is one of those glaring, it makes no sense. So during the COVID epidemic, we passed legislation that allowed nurse anesthetists to practice autonomously. They were able to do their job to better meet the needs of patients during the pandemic. Once the pandemic went away, we took that legislation back because advanced practice nurses, nurse anesthetists, for some reason, need to be under the supervision of an anesthesiologist, under a physician. So they were safe during the pandemic, but now suddenly they're not safe. Makes no sense.
there was a lot of weird things done.
Yeah.
I remember nurses coming off of new grads coming off of orientation early because they were, identified as being, ready to come. They thought that they were ready to come off, but you only get that orientation once,
Yeah.
especially as a new grad, just they should have been allowed to finish. But yeah, there was stuff like that where they made exceptions,
Right.
and then it's like they take it back,
Right.
And
From a legislative standpoint, it makes no sense. So they're safe then, but they're not safe now. And one of the arguments that the anesthesiologist will make was that, well, you need an anesthesiologist to rescue the nurse anesthetist if they're in over their head. Well, I don't know about your facility and my facility, nurse anesthetists are on call. They will be called in for emergencies. No anesthesiologist is going in with them. It's just the nurse anesthetist. So who's going to rescue that nurse anesthetist if there's no anesthesiologist there? We're saying, for on call, they're safe, they're competent, they can go in for emergencies. But otherwise, they've got to be supervised. It makes no sense. If they're able to practice fully without an anesthesiologist being there during the on-call hours, aren't they able to do it on the non-on-call hours? It just makes no sense.
so it's little things like that when you start looking at it analytically. It's just like, what, this is not adding up.
No,
there's things that just don't make sense.
Yeah. And another bill that I think is very important is the nurse education bill. I would say back in 2008, the legislators passed legislation that removed the ability for the Board of Nursing here in Florida to inspect nursing education programs. So the board cannot go in and inspect the quality of educational programs in the state.
Wait, how did that start?
But 2008, legislation passed that blocked the board from inspecting nursing education programs.
Which was who, I guess, brought that forward?
We would. The guess would be it was largely sponsored by for-profit nursing educational institutions
that want to just keep things moving.
Right. And so that's when we saw that proliferation of private for-profit nursing education programs. Now, their argument is that it increases the number of nurses, it increases access to nursing school for people who want to become nurses. I very strongly applaud that. But what it did was it allowed disreputable nursing education programs to grow here in Florida. And think about the recent tragedy that we had, where you had a school that was issuing diplomas without requiring the nursing students to actually go to classes. You walked in, you paid a check, they gave you a diploma, you sat for the boards. Huge controversy. Now, if you had a board that was able to go in and inspect, that never would have happened. So there was a bill this last year that would have allowed the Board of Nursing to again go in and inspect these programs. The bill failed.
So how does a bill like you talked about all the barriers to getting a bill? How does that bill just kind of slide through?
It was a priority bill for some of the key legislators, including the Senate President and the Speaker of the House. It was one of their priority bills.
So it comes down to them.
It comes down to them.
It comes down to them. They're the ones that actually make it happen.
They're the ones that have the influence. They're the ones that can reach out to the other legislators and move the legislation forward.
Which is where you run into barriers.
It's where
everybody
runs into barriers.
Yeah.
Not only us, but everybody who's advocating for bills, because those are very important, powerful individuals, and they control pretty much every piece of legislation at the state level and at the federal level. So bills can sit on the Senate President's desks or the Speaker of the House's desk as long as he wants or she wants. But they can also say, hey, I want this bill passed. And it passes because the legislators recognize if I don't do what the Speaker wants or what the Senate President wants, then they might not let my bill go through. So it's politics. It's politics.
Yeah.
And that's the system that we've developed. But sometimes common sense bills don't move forward, and bills that are actually deleterious move forward.
What happened to that nursing school? Those nursing schools?
The nursing schools that just gave people diplomas.
Yeah.
So those individuals who ran that have been prosecuted criminally. Of the nurses they're able to locate, basically for the ones who sat for the NCLEX and passed it, they've been able to withdraw their license and take them out of practice. Unfortunately, the school didn't keep very strong records. So the FBI is not sure that they got all of the students that did that. So, but that's an example of where...
So there's probably some nurses out there that never actually graduated.
Right.
Then
it's kind of scary.
It was like that one nurse, I think it was in Florida, that this was like a month or two ago. She, I think was a CNA maybe, and forged a bunch of stuff and started practicing as a nurse. And I can't remember what healthcare facility that was, but I went through HR, everything, somebody missed something, and she was working as a nurse for a while. And then they figured out that she's not actually a nurse.
Yeah. And so one of the things we need to do is strengthen those kind of background checks, making sure that we pick up on those. Not only in nursing, we have the same thing in medicine. We have folks who didn't graduate medical school practicing medicine in different states.
Is there anything that like registered nurses, LPNs, is there anything that they should be able to practice that they're not? Or is the answer for them, like if you're an LPN and you want to practice more, become a nurse. And if you're a nurse and you want to do more things, become a nurse practitioner? Or is there things that they're not doing that they should be allowed to?
That is a really good question. It's one of my pet peeves. So for the LPNs, they are vocational. So they really have a limited scope of practice, and they have to be practicing under the supervision of somebody, which is the registered nurse or the physician. I've got a little bit of an issue with them being under a physician because a physician never graduated nursing school. So they don't know what nursing really is. So LPNs need to be under the supervision of an RN. And that's just the way the system has been established. I'm not undermining their value. LPNs are usually valuable. They're great providers, but their level of education, you really need to have a collaborative supervisory arrangement with a registered nurse. Now, when it comes to a registered nurse, you are the professional You are the expert in nursing. So why do you need orders to do nursing from a physician who never went to nursing school? It makes no sense. So like the physician deciding how often to take vital signs. Shouldn't that be nursing? Aren't we the experts in that? Range of motion, how often to turn patients, different wound care treatments. That really is our expertise. That's what we do. And what's happened is we've allowed ourselves to fall into this, oh, I need a doctor's order to do that. As a registered nurse, you are a licensed professional. You are an independent professional. You do not need to work under a physician. We don't work under a physician. And so we need to recapture the practice of nursing and get our physician colleagues to get back in their own lane. So things like, vital signs and those kind of things, we shouldn't have to have a physician's order because that's our expertise. In addition to that, there is a good deal of data that shows that registered nurses are being grossly underutilized. There was a great study out of Canada where they took a group of registered nurses, and those registered nurses working under a protocol, so they had clear guidelines. They managed the diabetes for a group of patients. They managed the diabetes. They adjusted the medication.
In a hospital?
It was in a community setting. It was a community clinic. So they managed the medications. They educated the patients about managing their diet. They controlled the diet. And they were managing the diabetes. Now, yes, it was under a protocol. They were following a protocol. But they had the ability to spend a good deal of time with these individuals, educating them, building up the relationships. The study compared the nursing group to the endocrinologist group, the experts in diabetes. And we compared these two groups, registered nurses caring for diabetics under protocol, and then endocrinologists. And can you guess who had the better outcomes?
The nurses.
The nurses. Usually.
Why?
Because the nurses had the time to connect. They built the relationships with the patients. They formed that trusting relationship. And so the patients knew how to manage their diabetes better. They had a relationship with their provider, and they were able to better manage their medications at home because of that relationship. So I'm not saying we don't need endocrinologists. We very much do. But we should be utilizing registered nurses in the primary care setting to help manage these chronic illnesses, because lots of data shows we are underutilizing the registered nurse. And think about if we take the 2.5 million registered nurses and we start moving them out of the hospital, out of the acute care setting, into the communities, in these advanced roles, not as an advanced practice nurse, as a registered nurse, under protocol. Think about how we can improve diabetes, hypertension, other conditions such as congestive heart failure, by allowing healthcare providers who are trained to practice to the full extent of their education and training, as opposed to needing a physician's order for everything. So I think we're grossly underutilizing registered nurses.
Are they allowed to do that in Florida? Like what they did in that other study?
Well, it was Canada.
Yeah.
So Canada has a little bit more latitude because it's a universal healthcare system. Here in Florida, you can't. Our system is a little bit more restricted, but we need to look at the Nurse Practice Act. And the Nurse Practice Act allows registered nurses to do a lot more than we traditionally do. And, there are two phrases that we should never hear. One of them is, I'm just a nurse. We should never hear that. The other one is, I need a doctor's order for that. Especially if it's something within the scope of practice and within the specialty of nurses, because registered nurses are independent healthcare providers. We need to practice to the full extent of what we've been trained to do. That's kind of my...
Now, within if you work in a hospital, you're kind of, you have to follow what they're, like in the hospital, you have to order everything. Like you have to, you can't just do whatever however you want. You have to follow the guidelines of the hospital.
Right.
You're talking more about working in the community.
Well, the hospital as well. Why do nurses need an order for frequency of vital signs? Why do nurses need an order for whether or not a patient can get up out of bed to the bedside commode? There are things that we have physicians and nurse practitioners ordering that really are in the scope of practice and the specialty of the registered nurse. Wound care. For decades, the nurse was the expert on wound care. It was deferred to the nurse to decide what the best wound management would be. Why do we need physicians who probably have had maybe a couple hours training in wound management? Shouldn't we allow the nurse who is a specialist in wound management to prescribe that treatment?
I think it's just so ingrained now that like you don't even question it.
Right.
It's just so ingrained that you can't do that on your own.
And,
Yeah.
and the only way we're going to meet the needs of healthcare for this country is we let every provider practice to the full extent of their education and training. Everyone. And if we don't, we're restricting a body of providers that really could help improve healthcare, especially in need, at risk populations and populations in need. Physicians don't want to go to rural communities. Physicians don't want to work in poor, underserved communities. So how about nursing-led clinics in those communities? And there's lots of data that shows it works. In states where we've done this, including Florida, we've seen markedly improved outcomes in those clinics.
Yeah, that's an interesting thought that could really expand the care for those areas.
Yeah, but we would need legislation to do that.
Yeah.
So we need to build those relationships with the legislators.
Yeah. That is frustrating that it takes so much. I mean, one person can just throw off the legislation,
Mm-hmm.
and it has to take place in such a short time frame, and then you have to start over again.
So at the federal level, it's 2 years. So the legislative cycle is 2 years. So a bill has 2 years to get through. But in Florida, it's 8 weeks. So it's a very short cycle. And I talked before a little bit about we try to pass good legislation, but then we also have to block bad legislation. So pretty much every year for the past 5 years, the doctor title bill has been filed here in Florida. And the doctor title bill specifically bars nurses from using the title of doctor.
Like yourself.
Like myself, I'm a doctorally prepared nurse practitioner.
Yeah.
So it bars me from using the title of doctor. It doesn't bar pharmacists, it doesn't bar psychologists, it doesn't bar dentists, it doesn't bar chiropractors, it just bars nurses.
Which is weird because you can get your doctorate in anything.
Right.
And you're a doctor. I mean, not a medical doctor, but you can get your doctorate in almost any subject you want, and you're referred to as doctor.
Right, because doctor is an academic degree. And the legislation would bar advanced practice nurses and other nurses from using the title doctor. And their argument is that it confuses the patient. And I don't know of any advanced practice nurse or any doctorally prepared nurse who doesn't explain when they use that title who they are, because they're proud of who they are. So I don't typically use the title of doctor, but when I do, I make it very clear. Hi, I'm Dr. Briggs. I am a nurse practitioner. And my patients understand that. And so that's a bill that we block every year, and it gets refiled every year. So one of the key things that both the Florida Nurses...
Who is filing that?
The Florida Medical Association is the main sponsor. Yeah. And so the FNA blocks bad bills often, but to do that, we need the support of the nurses in the community. And the American Nurses Association also blocks bad bills. And so we need nurses supporting both the ANA and the FNA to do it. So one of the things that the Florida Nurses Association and the American Nurses Association spends a good deal of time on is moving good legislation, but also blocking bad legislation. So the doctor title bill is an example. There are multiple other bills that we spend a great deal of time trying to block. And it's important that we have folks engaged with the ANA, with the Florida Nurses Association, and for the advanced practice nurses with the Florida Nurse Practitioner Network or the Florida Advanced Nursing Practice Association. And again, you don't have to belong to one. You should belong to all of them. So I'm a member of pretty much all the organizations because we need to support these organizations so that they can pay for a lobbyist. And that's where a lot of the money goes to, so that they can be in Tallahassee, be in Washington, D.C., and work on these bills. And I wish I could say money's not the issue, but as you said before, money is a factor. I mean, you can't buy a bill, but you need to get in the door. And sometimes a $5,000 check is what gets you in the door so that the legislator is willing to spend time with you and hear your issue. And so to get that money, we need members and we need folks that are engaged with the political action committees.
What's your advice for a nurse that doesn't feel like their voice is being heard, or I mean, even at a hospital, like how do they make their voice heard all the way from the hospital all the way to Tallahassee and Washington? What would be your advice?
Well, at the hospital level, one of the things that we need to be is engaged, and we need to act as a profession. Okay, so you need to be on key committees that are making key decisions. And if you're at a hospital that doesn't have committees, you need to look at another hospital, because those hospitals are not utilizing nurses the way they ought to be. So nurses need to be on key committees. We need to have our voice heard, and we need to be guiding policy at the level of the hospital. So for example, at Bay Pines, where I practice, I'm on the clinical practice committee, and several nurses are on the clinical practice committee. This is the committee that makes decisions about policies and procedures, not only for nurses, but for the entire hospital. And so by nurses serving on these committees, our voice is heard, and we can guide the practice in our facilities. At the state and at the federal level, again, if you're not at the table, you're probably on the menu. So you need to be at the table, meaning that you need to get engaged with your professional associations or your specialty organizations. You need to be heard. And anybody out there who says, well, I've never done that before, I don't know how to do it. When I started, I had no idea what I was doing. But there was one individual who recognized that we need to be engaged. And she pushed me into it, and I greatly thank her for that. But you need to recognize that your expertise is not coming from how many people you lobbied. Your expertise doesn't come from whether or not you've been up to Tallahassee. Your expertise comes from being a nurse. And that qualifies you to serve on any organization within our profession, so the Florida Nurses Association, Florida Nurse Practitioner Network, but also outside of our profession. So there is an organization, nurses serving on boards. Okay, it is a national organization that pairs nurses up with boards that are looking for nurses to serve on those boards. We're talking committees for boards governing transportation, boards governing education, schools. And you might ask, well, why would you want a nurse on a transportation committee? Well, who knows about individuals with disabilities more than nurses? We know about those physical limitations, how to address them. Schools, same thing. We know about healthcare in school systems. And so we need nurses to serve not only on our professional boards, but also on boards outside of our profession. And so we need nurses to be willing to step up and volunteer to serve on those boards.
Yeah, I don't think most people would think about serving on and that's not the first thought they have.
No.
Is how am I relevant to the education board or the transportation or anything like that? But they got to get involved somehow.
Right. And, when those school systems are thinking about caring for individuals with disabilities, or busing systems are thinking about how do we deal with folks that might have handicaps and physical disabilities. When those organizations think about it, more than likely they don't have somebody sitting on the board that knows about it. And so they kind of struggle. Where a nurse typically has experience with those and can bring a real world perspective to those boards. So that's why the Nursing on Boards Coalition is formed, and it's very successful, getting us to serve on boards where our expertise is a valuable asset to those boards. So I would encourage every nurse to go onto that website and take a look. And then if there's something they're interested in, volunteer. You may not get an appointment, but you might. And in my opinion, by them serving, we're benefiting our communities. Any nurse that wants to serve on the Florida Nurses Association or your state association, sign up to run. Get your voice heard. Drive the policy. If you're not driving the policy, then somebody else is. And in that case, they may be driving a policy in a direction you don't want to go. Same thing with the American Nurses Association. That is your professional organization. We have committees, we have the board, we have action groups that are all functioning to better advance our profession. And as a registered nurse, that's your qualification. You are qualified to serve in those positions. So volunteer, step up and do it, because that's how we make a difference.
I want to talk about you were talking about websites and stuff. It's your website, right?
Yeah.
Is it aprnadvocacy.com?
Right, aprnadvocacy.com.
And that's where you share like anything that's going on with nurse practitioners and advocacy and the government and all that?
Right.
Okay.
So the goal of the website is we understand that, we do a good job of outreach to advanced practice nurses in our state. We have multiple organizations that really get out there and lobby the advanced practice nurses, educate them. We don't do such a good job at educating the community, registered nurses, and other individuals. So I created the APRN Advocacy website with the goal of outreach to registered nurses, to community members, and then to advanced practice nurses who may not be as engaged. So you can find resources there about the organizations that are members of the Florida Coalition of Advanced Practice Nurses. Basically, all of the advanced practice nursing groups, we meet on a quarterly basis. We look at what the policy issues are facing our state, and we try to find consensus on how to address those issues. So basically, we all work together. And so we utilize the website as a tool to bring us all together so you can find out who's on the coalition. But then also on the website, we have resources about legislation that's pending. What you can do as an individual to help move legislation forward or block bad legislation. In addition, I just posted the calendar for this legislative year. So the committee meetings will begin in October, and then the Florida legislative session begins in January. So between now and January, the Florida legislators will hold what they call delegation meetings. And delegation meetings is open meetings. Delegation meetings are open meetings in the local districts. And at these delegation meetings, the legislators are there to hear from their constituents, from the folks that they're representing. So typically the delegation meetings will be all the elected officials for that region, meeting with whoever attends these sessions. And you can sign up to speak at these sessions. So this is a great opportunity for you to meet with your legislators, to be heard, to share your perspectives on what's going on in your community. And so I've posted the dates for the delegate meetings across the state. So if you go to APRN Advocacy, you'll see the 2026-2025 legislative session. Click on that link. It'll show you where the delegation meetings are, when they are, and if you want to meet with your legislators or just listen to what their priorities are, the delegation meetings are a great opportunity. So that's one of the great resources that are on that website.
Yeah, I think that's a good idea. Just creating that website and letting people know, even if they don't have time to be on a board, they can at least go to a meeting and make their voice heard that way. Maybe they don't have maybe they don't have the time, commitment, or whatever to be on a board. They can at least do that. They can at least go to a meeting and make their voice heard.
Yeah. And I'll share with you the last 2 years ago, I went to the delegation meeting, and it was the Pinellas County delegation meeting. And there was an organized group of individuals who opposed vaccines. And they were extremely well organized. They were extremely vocal. They all got up to the mic. And one of the challenges we had was that there was no one there presenting the evidence-based position. And the legislators heard that one voice and didn't hear any other voices. And so these are opportunities for individuals to present their position to their legislators. And we need to remember that it's also our opportunity to present our positions on key issues to our legislators. So when the physicians talk about we need to restrict advanced practice nurses at these meetings, or hospitals talk about we can't have safe staffing because it'll bust our budgets, when those entities are there at these meetings being heard, we need to be there as well to present the factual information, to say the facts about those issues. Because if we're not, then the legislators are only hearing one position, and it may not be the position we want them to hear.
Yeah, makes sense. Um, Kind of wanted to change subjects for a little bit and have you talk a little bit about your work in the going on these like medical missions trips, I guess you would call them, where you're going to other countries. Which country do you go to?
We typically go to Belize.
Belize. And your whole focus is just to provide care for those who are underserved.
Right.
It's a voluntary thing. You guys go with a group and pay your own way, and you
Yep.
just go down there for a week or two and provide that care. Just maybe tell a little bit about that.
Sure. Our organization is called No Kumbaya. We're not there to sing Kumbaya. We're actually there to help people. So that's the name of the organization. We're officially associated with the Lutheran Ministries, but we're non-proselytizing. We're not there to convert people. We're there actually to help them. So we go to remote mine villages for about a week. We pay for our own way. We fundraise to buy medications. We go up and see these patients. We treat their acute injuries. We treat their chronic conditions. We provide them with demurring medicine, or if they have scabies or lice, we address that as well. For folks with chronic conditions, we will leave them with the medications they need to manage their chronic conditions. We educate folks about chronic conditions and how to stay healthy. And one of the things we've seen in the work that we've done when we first started doing this, 60 to 70% of the population had malnutrition caused by intestinal worms. Just us going up twice a year deworming them reduced malnutrition in those communities. In addition to that, we recognized this most recent trip that we did that a lot of the young individuals were developing cataracts and they were developing pterygium, where the conjunctiva is growing over the cornea. And the reason that was happening is because they're out in the fields all day, exposed to sun, and they have no eye protection. So we bring UV protection sunglasses. Something as simple as that will prevent cataracts, will prevent pterygium. And so we're not providing comprehensive care. We're not there around the clock, but we do dramatically improve their health, and we educate them about water safety and other conditions. In addition to that, part of the mission is we go into the schools. We do wellness physicals. We make sure that the children are doing well with their dentition. We bring toothbrushes and toothpastes just to meet basic healthcare needs, because this is a population that doesn't have any access to healthcare. And we see that all around the world. You yourself go on medical missions. So you know some of these individuals have no access to healthcare. So the little bit that we provide actually makes a huge difference.
Are those open to anyone?
Anybody can attend.
Anyone? And who do you take? Doctors, nurse practitioners, nurses?
Doctors, nurse practitioners, nurses, lay people. Half of our team are lawyers. And lawyers are great in the pharmacy because they're very anal retentive. So they make sure that, everything lines up. So we take anybody.
Okay.
And again,
what's the name of if someone wants to find out more?
Sure, it's No Kumbaya, NOKUMBAYA, No Kumbaya. Again, we are associated with the Lutheran Church, but we're not there to proselytize. We are there to meet the needs of the individuals. So it's hard work. We spend a great deal of time doing everything we can to help these people. And we're not there just to hand them a Bible and say, you're all better now. We're there really to address the healthcare needs and improve outcomes in that population. And
I've been on several medical missions trips, and they're always rewarding. And just, you look at the conditions that they live in and what they consider healthcare and what they're thankful for. It's like you come back and you're like, man, sometimes these patients complain about stuff, and you're just like, you have no idea how good you have it here.
Yeah. And one of the things that we see is that by far and large, the majority of these people are very healthy. They greatly appreciate the care that we provide. And we come into it as nurses with the perspective of recognizing that we are moving into their culture. And so we have to recognize that we can't, they've got their tribal medicines, they've got their traditional treatments for things. And as nurses, we recognize that we can't tell them don't do that because they're not going to hear us. This is what they've done for probably centuries. And for us to come in and say, don't do that, it's not going to work. We have to take the perspective of, well, keep doing that, but let's add on this antibiotic or let's add on this wound salve. And often our physicians colleagues may not recognize that. They very much come from the medical model of, you have to do this. So I think as nurses, because we have that human factor, that we deal with people on a very intimate level as nurses, we're a little more receptive to respecting those cultural differences and allowing those cultural differences to be incorporated into healthcare. And I think it's one of the real benefits nurses bring to medical missions. We recognize that we have to work with the individual, not prescribe to the individual.
So I want to ask you, I ask everyone, and it can be a long answer or it can be a short answer. What's being done right what's being done well in healthcare? What needs more attention, and how do you accomplish that? I know some of this we already talked about, but just maybe in summary, answer those three questions. What's well, what are we doing well? What do we need to work on, and how do we get to that point?
Sure. So what we're doing well is we're seeing expansion of nurses being utilized. We're seeing expanded scope of practice, not only in advanced practice nurses, but in registered nurses. We're seeing there's a record number of registered nurses who are now CEOs of hospitals. So we're seeing nurses step into the roles that were really meant to be in. So I think we've begun this trend that I think is well overdue. And we need to continue that trend. So we need folks to step into those roles. I think that's what we're doing well. I think where we're not going so well is we're seeing partisan politics very much become a driving force in healthcare, and we can't allow that to happen. We need to recognize that healthcare and nursing is a science, and we need to let the science guide us. We need to let the evidence guide us. And when we have individuals who are proselytizing conspiracy theories or non-evidence-based information, we need to recognize that that is not factual, and we need to take a stand basically saying, this is not appropriate because this is not evidence-based. And if we're going to call ourselves an evidence-based practice, then we need to follow the evidence. And we need to make sure that everybody is doing that. And that's not a partisan argument. That's a scientific and a health policy argument. We need to let the evidence guide us. And where there's not evidence, then we can have a debate. But on certain issues, there's very clear evidence. And so we can't let conspiracy theories or some salesperson trying to move forward a product that they have guide us. We need to let the evidence guide us. And I think the way we're going to get there is we need to educate our professionals. We need to educate our colleagues and our peers, but we need to educate the community. When we see individuals advancing conspiracy theories or advancing things that are not evidence-based, we need to step in and say, hey, I understand that's the way you feel or that's what you believe, but this is what the evidence shows. These are the factual data points that we need to utilize in healthcare delivery and health policy. Because we need to be an evidence-based profession. So we need to let the evidence guide us. So I think as nurses, we are strongly positioned to be a voice for evidence-based practice and to oppose a movement towards this conspiracy-driven healthcare delivery system. If you've got evidence, fine, let's talk about the evidence and let the evidence guide the policy. If you haven't got the evidence, then it's a conspiracy theory. And we can't let that guide healthcare because that's going to harm us as a profession. It's going to hurt our communities, and it's going to hurt our nation as a whole.
One last thing. If someone wants to get involved now, how do they get on the Florida Nurses Association or become a member? And then how do they also do that nationwide with the American Nurses Association?
Well, when you join the Florida Nurses Association or any of the state organizations, whether it's Florida, New York, wherever, you automatically become a member of the ANA as well. So when you join your state organization, you also become a member of the ANA. If you want to serve on committees, just reach out to your state organization. They're always looking for folks to be involved in committees, and they'll move you on to committees. If you want to be on the board, if you think you have an issue that's important to you and you want to drive that issue, getting on the board is a great thing. So every year, your nursing organization is having elections, and you need to step up and run for those offices. And so become a member, become active, run for a position, and make sure your voice is heard. And frankly, I'm a very strong believer in we don't need a monolith discussion. We don't need everybody saying the same thing. We need a diverse board that is bringing different perspectives. And from those perspectives, we're finding the best way forward. So new nurses, experienced nurses. I am now considered a senior nurse. All the different folks from community care, mental health, critical care, ER. We need all of them serving on our organization boards so that we're bringing our unique perspectives. And that benefits the organization. If you've just got administrators or you've just got educators serving on the boards, you're not getting the full picture of what healthcare is. So we need diverse boards, which means we need folks willing to step into board positions. So anybody who's interested, I strongly recommend you run.
And especially newer nurses too, because I just think there's a lot of value in people who still work on the floor.
Yep.
And still newer nurses who they may not think they have not a lot of experience, but they're fresh working on the floor and seeing things that someone that's maybe been on the board or out of that bedside nursing may not have that perspective. So even a brand new nurse can add value to those things.
So both the Florida Nurses Association and the American Nurses Association have a delegated position on the board for a new grad. And I'll tell you right now, our new grad serving on the ANA board is amazing. She is truly amazing. And so her voice is an important voice for the board. And so we need new nurses. We need new grads being on the boards and making sure that their voice is heard. But we also need senior nurses. We need nurses in education positions. We need nurses in acute care and community care so that everybody's represented so we can get the full picture. Because these boards are driving nursing policy. And if not every voice is heard, then we may not be driving good policy.
Yeah. Well, that was all great information. Thank you for taking the time to sit down and explain all that. I know when it gets into the politics and all that stuff, it's I don't think I didn't understand all that stuff, how those bills, have to go through all that stuff. So I think hopefully it'll help people to understand kind of how that stuff works and what they can do to make their voice heard. So.
Yeah. So I encourage everyone to get involved. And if nothing else, try to get to your local delegation meetings. Just sit and listen. Hear what the issues are. And you'll probably walk away maybe a little bit angry, but definitely excited to do something about it.
All right. Well, thanks for coming on.
Thank you for having me.
Yeah.